such a pleasure to work with you as well from your foundation and now unofficially recruiter for Judson. So, and I appreciate the students who are participating today. Um, Please make this be a dialogue with us as I share. I will be maybe talking a little bit more medical perspective, but if there's something that I need to clarify, please just stop me and let me know because my world is so ingrained in healthcare right now. And on a daily basis, I'm communicating with other nurses and physicians, and so the language sometimes change from everyday language. So please keep me honest. Just to share a little bit, I know Dr. Love already pointed to some of my background. I really started, just to share my story with you, I really started my world in the business world, management information system, and total quality management. But I wanted something different. I wanted something that fulfilled my purpose. And then I looked at what was out there and I said I'm going into nursing. And I have not regretted that decision. And it's a blessing that I have come full circle to the point where I can integrate my nursing background with my business and information technology background. I can walk into a room and talk with what they call the techie guys or gals, leadership, or I could be talking to a physician and I can help with the translation of the two worlds. It's just a blessing to be there. And then working as a consultant, I've also been blessed to be able to travel the country from the East Coast to the West Coast and North. I've worked in hospitals in the North as well and assist them with their transition, their business strategy of integrating more of an IT platform into medicine. And so I've seen a lot as I travel throughout, and I've used my knowledge for every organization that I've worked with. And I've worked with Trauma One Center like Frederick. I've worked with the Cleveland Clinic. And now I'm in Pennsylvania with another Trauma One Center. That is just huge in a consulting capacity. And so I really, really feel blessed to be able to do that. And I also feel blessed for the moment that we met and we talked about my passion of giving back to Jamaica and the education mission that we are working on. I've done 2 missions now, 2 years, and had it not been for the COVID pandemic, we would be going there in July. So I'm a little bit sad about that, but understandable. Hopefully we'll continue that next year once this is behind us or we have some level of control. So I look forward to that. I'm also happy that we've been able to partner with Judson and is looking to bring students to Judson campus from Jamaica. We have some really talented students who, when given the opportunity, would do great things in life. And so that's what we're working on as well. First question for those on the phone. Has anybody heard or familiar with the term nursing informatics?
Not until I met you.
No, I have not.
So this is really a new role in nursing. It's a master prepared level through the American Nursing Association and ANCC certification body. They started more promoting this role back in 2009 with President Obama. It was there before, but it wasn't publicized. Maybe 1 or 2 people you could find throughout the country. But this became a role that was of significance when the Affordable Care Act was passed and the HITECH Act was passed. And what it said was by 2015, every hospital, no, it said every patient throughout the United States should have an electronic medical record. And I believe his purpose has been fulfilled by the 2015 date. And so if you go into the hospital, if you go into the clinic, if you go into a surgery center, everybody has what is called a MyChart or an electronic portal. That was part of the plan. And even though presidents before President Obama had promoted this, it wasn't given life until funding was applied. And so what this role does, this is a specialty of nursing, and what we seek to do is to integrate nursing science. So the principles that we followed in patient care for nursing, we apply that. We apply the principles of computer science, which has to do with information technology. and incorporating that at the bedside, and other places throughout the healthcare system. We also integrate information science, meaning that we're receiving data, we're processing that data, and we're applying that data to make key decisions, strategic decision, whether for the organization, for patient care. How do we make patients' life better? And so we have seen this specialty taken life, and I've taken on that role to be able to serve understanding IT and nursing and be a bridge for the clinicians out there. So that's what that is. We're serving in many areas. We are serving in administration, we're serving in leadership, we're serving in education, we're serving in research, and even more so today. So all of these and more, we are serving in those areas. With the COVID-19 pandemic, we are using information technologies infrastructure to help support what we do. And I will share some of that as I go through this presentation today. You'll see even more now, this role is so critical to making the wheels turn and making change, positive change, finding solution for hospitalists, for physicians, for nurses, for patients. We're filling the gap to make sure that that happens. And I'm able to serve as a consultant outside the organization, a brain coming in to help solve challenging problems. And I do this mainly by my work with the electronic charting system. Okay. So the purpose for today is to focus on hospital preparedness during this COVID crisis. And again, I will come to you from my inner perspective, what I've seen, what I've done, what leadership has been doing, what infrastructure we've had in place, and just take you through that story in my life. Mm-hmm. And if you do have any question, please just raise your hand, let me know, just chime in, and I will just pause. Before I continue, what questions do we have so far?
As a consultant, is this your business or are you working with another organization?
That's a great question. So there are a lot of recruiters out there. Like sometimes you have headhunters or you have different firms that specialize in finding the right resource. Mm-hmm. And so if there's a hospital that's in need, they would reach out, whether by contractual or just putting a publication out there. We're looking for this type of a resource to help us meet this challenge in our organization. And those recruiting companies would then reach out to us. Some of them look you up by LinkedIn. Some of them you've had relationship with over time. And so they're always keeping in touch with you, finding out if you're available for a particular project. And so I'm not affiliated with any one consulting firm that hires. It's a matter of where the project is. So I could be working with 3 different consulting firms for a given year, or one for a 3-year period. So it varies. That was a great question.
And then the Trauma One Center for Cleveland Clinic. Mm-hmm. Could you, in what capacity are you serving? And
so for that, when I worked with them, they had acquired a new hospital system. Mm-hmm. And so they were looking to integrate their charting and extend that over to that new system.
Okay.
And that system is actually what brought them that trauma one capacity, because you have different levels of trauma. Your McHenry Hospital isn't necessarily capable. So by acquiring this new system, we had to technically give over or get them transitioned over to Cleveland Clinic's charting platform. Okay. So everybody's speaking the same language, integrating leadership, stuff like that. And also there was a change with government in terms of how, like the ICD coding, like when you go to a hospital, you're given a diagnosis, you have hypertension, you have diabetes. Behind those are special codes that's used by billing services. I had to help them transition that new, more granular system, put that in place as well. So I'm really helping with implementation, install, enhancement for their hospital, mainly focusing on the documentation portion of it.
Very good. Other questions?
I have a question. Do you have to have a background in nursing or any kind of degree in nursing in order to get into this information type part of the business?
To be a certified nursing informaticist, yes, you must have that nursing background. For you to be certified, there are certain requirements of having a master's degree, having practiced for so long in IT space, and then you could take the certification through this certification body that like certifies your nurse practitioners, your nurse midwives. They'll certify you as well in this practice. There's also what is called medical informatics, and there are some other generic informatics that's out there. But nursing informatics, you must have that background.
Okay.
Yeah, great question.
Yeah. Other questions? Well, I have a question,
Yep.
Nardalyn, and maybe I should wait and ask this question, but
That's
I
okay.
want to know, how will the government use my medical records to determine whether I'm healthy enough to be integrated into society again?
That's a great question, and I'm not sure if they're going to be using it that broadly in terms of you, but they can collect based on the information. So when you come into the hospital, we're taking certain information. How sick are you? Especially with the COVID pandemic. And I'm assuming you're thinking of the COVID pandemic, correct?
Yes.
They're looking at from our area, how many patients are coming into the hospital, not necessarily you per se, but do we have enough hospital capacity based on all the patients that we're seeing coming in through our emergency departments? Are we overextended? Do we don't have enough hospital space? How many patients are dying? Do we have enough staffing? So they're using all these models, or they're supposed to be using the data that's given to them by the organizational leadership, which is the hospital leadership, getting this information out of the electronic chart. What patients do we have? How many do we have admitted today? How many did you admit yesterday? How many are you admitting today? Are you seeing that trend going down? Or they also have what is called a dashboard, and with a glance, they can see, is hospitalization going down? Are we having less positive cases? Are we having more positive cases? And so they can use that, what I call the dashboard, to gauge where that population is at for your particular area. And then taking it on a more national scale, if they aggregate that data that is coming out of the electronic charting, because we can pull that data. I'm surprised how much data we can pull today based on documentation. They can aggregate that data and make informed decision from it in terms of opening, not opening. Do we have the test? Do we not have the test? Are people getting tested? Are they getting turned away? What are the diagnoses that are coming in? How many positive cases do you have? We can tell all of that just by you coming into the system, getting a blood test done, getting that testing done, getting the results, pulling that data together.
Are you
Yeah.
concerned with the government's access to our medical records?
No.
Okay.
Not to my knowledge, not from my level, from where I sit. We do have to give them reports, and it may not, well, I shouldn't say that. They wouldn't have access to fully everything, but they can get reports. Like, we could send them reports, and this is the data that they want. So, for example, the Department of Health, and I'm referring to Pennsylvania now because that's where I'm stationed right now. When the COVID pandemic started, we have to figure out a way through the electronic infrastructure to send them daily reports of patients that are coming in, and we had to tell them if that patient was reporting positive or negative. And so there's certain information that we have to share with the government. It's the same as your vaccine. If you've had the vaccine, it's part of a registry. And so they can get information. There's certain laws that we have to adhere to from the Department of Health. How much they're looking at you, the one person personally, I don't know. But now I could tell you they could, but I just don't know that, because if they want to contact trace who you've been with in that area, they could see, okay, Dr. Love was in, Crystal Lake. She went to this hospital. She got diagnosed. They can pretty much trace back based on they can request information from us. And because it's more of a pandemic, we have to share that information and make it available to the Department of Health if they need it. And it's more for community um, safety of the community and reporting that information. But there's a lot of safeguard. I should tell you that there is a lot of safeguard, and I don't know if you know this, but if you've gone to a hospital system and you want to know everybody who's accessed your record, you do have the ability to do that. You can go to the medical records team and you could ask for that information, and they're obligated to give it to you. You have to sign waivers, of course, but you can know who's looking at your chart if they're actually in the hospital. But if we're reporting out, there's certain information you can see. I'm not sure how much though, but there's a team who focuses on that. It's a long question to a long answer to your question. But they're collecting data. We're sending reports, how they're putting it together, if they're targeting. We're going to assume positive intent for this pandemic and using the information wisely to make informed decision about the population health.
Yeah, good.
Right.
Additional questions? Okay.
All right. So I'm going to go back to the beginning from an organization perspective of what does it mean to be emergency preparedness. And like I said, I work with the emergency department team. And so we actually started back in January, believe it or not. I remember just walking down the corridor casually, and I got pulled into a meeting. Anybody ever just got pulled into a meeting that you have no clue what it's about? Well, that's what happened. And within that meeting was the lead physician, the CMIO, who is the Chief Medical Information Officer for the hospital, and the lead infection control prevention lead guy. And what they started talking about was this place called Wuhan, and I had no clue what this was and where this was and what was going on. And all I know, they were really concerned about what was going on there. And they were concerned about that getting here. Of course, I didn't understand the granularity of it at that time, but this was back in January. And we started having meetings with infection control in the hospital way back in January. By February, I believe it was the first case reported in Washington. And we got an emergency meeting again and say, oh, we need to know if a patient has traveled to China in the past 30 days that shows up at our emergency department. And I'm immediately thinking, like, how do we use technology to help provide this information to them? And by the end of the day, we actually implemented within our infrastructure, in our electronic system, if a patient walks up to our emergency department, we ask them the question, have you been outside the country in the past 30 days? They say yes, we document where they've been. As soon as you say the word China, behind the scene, we're sending a warning flag to our infection control team for the hospital, letting them know that there's a patient who meets the criteria that we set up, the logic we set in the system, and potentially to monitor for that infection. So we don't want to get this further beyond that initial contact within the emergency department. And so we had that in the system, and we've been monitoring every patient that has been coming through our emergency department since that time. And so what I find is that we had to have a plan, and the plan was we were meeting twice a day with leadership. We know that we're expecting the unexpected because I realized things were changing daily since January. The also important thing is having the right team, meaning that we're engaging with the physicians, the nursing teams, the IT team, infection control team, and we're looking at patient safety, staff safety. How do we keep our staff safe? And we found a lot of what we can do is we're leveraging the technology that we already have in place for them. So that was important for me. And when we talk about emergency preparedness, we're thinking about who's your global team? What are all the teams that make up the critical component? And I'm just pointing out a few here. Myself as part of the emergency department team, then we have our inpatient team, we have our surgical services, we have outpatient, pharmacy, laboratory, training team, the medical records team. How do we get us ready in the right mindset to tackle what was coming towards us? And this was a huge challenge for us. And then I'm doing that storyline time frame, by about March 15th, thereabout, we got the notification from our leaders that we have to all work remotely. So all these teams, all of a sudden, within a day, by the end of the day, all you're doing is taking your laptop with you, right? Because you need that to work. And some people were taking their desk home as well, like literally taking the ergonomic desk with them. So we did that, and we've been working remotely ever since. And we have been working strategically with the virtual command center, because any change that we make, and these change were constantly coming at us every single day. And so we have what was called that virtual command center, again, made up of the physician leadership, the director bodies, the IT staff, and then you had the different teams that made that up. And we were planning every day, what is going on, what are we seeing, how are our patients doing? And each team had to report up to the command center every day, what are we working on, what is changing, what is coming, and every day was something different. This is a huge paradigm shift for hospitals, because we work in an organization that we need close contact, right? How do you care for a patient that that you're not there? And I'm going to tell you about some of the things that we're doing. So this paradigm shift saying we cannot have the patient inside our emergency department, because if you think of a patient coming in, by the time you diagnose them with having the COVID, it's too late. They have already infected all your staff in the emergency building itself. And so we got to we called it open air tent, right? Which is now that everybody knows a tent outside.
Yeah.
And so we had to build a tent. But what does that mean? How do you care for a patient in a tent? You have all these systems that you have to put together.
Mm-hmm.
And so everybody kind of descends within the tent. So you drop everything you're doing and you kind of, work towards this goal. We have to set up a tent, and we have to get our technological infrastructure in place. We also have to get training in place. So we had to get all our printers, we had to get all our computers, we had to get all the beds, the stations. We had to set that up as if it was an emergency department, but outside. So that's how we control the infection from getting in, by using that open air. One other thing to note is that when you have the COVID virus, they put you in what is called a negative pressure room. So it's a special room that prevents the air from getting out and contains that circulation somehow. But by having you outside, you don't need that, because you wouldn't have enough beds within your ED for if several patients showed up that were positive. You don't have enough beds to control that. So what they did, we put them in the tent, and we start from the tent. We're doing our triaging outside. We're determining if they're positive, negative, where do they go from there, and we do the triaging that way. We also continue to do our assessment, as we always do. With any pandemic, risk for suicide is also increased. And so as emergency department staff and nursing, we are always assessing patients coming into the emergency department for suicide ideation. Are they safe at home? So we continue to do that. And with the infrastructure that we're able to provide, nursing staff were able to carry on outside as if they were in the building itself. One thing that we also found was that we don't have enough physicians to cover the patient load that were coming in. And so how do you manage that? Is leadership, right? Because you don't have enough physician to see the patients. And so what we started doing was looking at ways to get nurses stepping up to the plate to help physician through this process as well. So that was also unique for us, and we had to turn over our system. We had to make changes, big changes within our system in a short amount of time to facilitate nursing assistant physician with their workload. So that was a huge paradigm shift for us. Yeah. Okay. So using technology and the infrastructure that we have today has been really a whirlwind for us. If I think back even 3 months ago, most nursing did not like, they really weren't computer person, and they'll tell you that all the time. And now a lot of our world exists with computers. and how do we use that to help decrease the spread of the virus. And I'm going to share some of that coming up.
Okay.
But even with the classroom, think about the leadership at Judson and what you've had to do within a short space of time. If somebody came to you back in January and says, oh, we're going all online for classes, I'm sure you'll get a couple chuckles out of that.
Mm-hmm.
Even though for many years we've been offering online degrees. But to get our mindset out of where we were was unthinkable.
Mm-hmm.
But now with the pandemic, we had to change our thinking. We all had to change our thinking, whether we're in healthcare, we're in education, we're in manufacturing, we've all had to change what we're doing. And so we think of the infrastructure that's around us. Think about the phone. We're going, we can't physically walk over to somebody's desk and talk to them. So now we're picking up the phone and we're making phone calls. We have to keep up with our emails, even more so now. Think about how we're conducting meetings, in our businesses. Training is another thing, because we've had to think about taking away from classroom training. How do we train new physicians coming on? How do we train new nurses coming on? And so we're leveraging the technological infrastructure that we have to be able to do some of that. Guaranteed is not 100%, but we've been figuring out how to do it quite a bit. Doctor visit. Many of us got the automatic, we call them the robocall, to tell you that your appointments were canceled. That's something that we had to do early on too. We had all these surgeries that were scheduled, and working with leadership, they have to say, okay, we have all these appointments. How do we notify them? They had and I don't know the technology that was used, but it was a voice technology, and they were able to send call out to the patient, in addition to leveraging some of we call the patient portal, which is access you have in your own home to your own records, leveraging some of that as well for notification, for doctor visit. For mental health, we're seeing that professionals are going online and offering their services to help that population who needs some mental health services. The electronic health record, and I have this in green here because it's huge. It has played a central role in what we are doing today, how we're communicating, how nurses are documenting, how we're taking that information that is entered into the system and disseminating that information, using it to make decisions about what next, right? E-visits. I had my first virtual PCP visit today. Well, that was new to me, right?
What's a
It's a primary care, sorry,
okay.
primary care physician
Okay.
visit. And so you have to decide, do you want to go in or do you want to have this virtually? So I had the first one I did today. That was quite interesting for me, only because you're really having a conversation, but the assessment that goes with that, look in the eyes, look in the ears, look in the mouth,
Mm-hmm.
Listening to the chest, listening to the lungs, you can't do any of that. And so to me, that was new. Something happened today too. I saw what we're going towards, a video consult. And I saw that, a video consult. This is going live next week. I go, what is a video consult in the emergency room? How do you do video consult in the emergency room? I'm showing up as a patient. I don't expect to be on a computer talking to somebody.
Right.
So what this really is if you have a resident working in your emergency department, and a resident is a physician in training, and he needs to talk to you, you're thinking of admitting somebody to the hospital, you need to have a consult. They are now going to use the iPad and work with that resident, so the physician doesn't have to come into that space. Again, keeping that social distance, they don't have to come into that space. So they are now looking to do video consults. Again, a new thing that is everybody's learning about on the fly, and things are changing really quickly. One other thing that's not on here, but I saw it come out today, that the infrastructure that we're going live with, One of the challenge we have in healthcare is that a lot of times you're separated from your family and you cannot, no one is there with you in the hospital. So how do we keep the family informed? How do we tell, Dr. Love, how do we tell your husband you're doing okay and what's going on? You're having a test, you expect to be discharged. We are now looking to implement a communication system so the nurse can send an email communication with updates as long as you, the patient, have consented to that information being sent. We can now send that email to you, to your family member directly. And that's an infrastructure we're working on for next week,
Mm.
actually. So
A fluid situation indeed.
it is such a fluid situation. We are changing every day. So we've really integrated technology into the infrastructure for healthcare in a paradigm that we didn't think about before. We're using it for surge capacity. We don't have enough hospital beds. We have to make hospital beds. We have to be able to track where our patients are, which beds there are. Are they in a tent? Are they in a hospital room? Are they in the emergency room? Are they waiting in their cars? We have to account for that capacity. Right now, we're able to go to a special testing system where the physician just has to place one order, answer a couple questions, and we can determine if that test will be performed in-house, if it needs to go to a Quest lab, an outside lab. Do we need to send it to the Department of Health for processing? And you could think about all those pieces, and we are just giving them one test. And based on their answer, behind the scene, the infrastructure is taking care of where and how we process, where does it go, what does somebody else needs to do next with us. We're doing a lot of reports to the local, federal, state government. We're leveraging telemedicine a lot more now within healthcare. Another huge thing that came up is if we have a patient that comes into us and they're positive and they were taken to us by the ambulance company, we have an obligation. This is the law. We have an obligation to call that EMS, emergency medical service, that ambulance company, and let them know that the patient that they brought to us a day ago, 2 days ago, has now tested positive. So they can do their contact tracing as well. And so we're using technology to do that, to help us with that. So we can run a report that tells us all the patient that came in by an ambulance, what ambulance they came in with, what's the ambulance contact information, and from there we can notify them that that patient was COVID positive, so that they can take the necessary steps as well for their company. And then I talked about the family communication that we're integrating iPads. We're doing Zoom with the family. We're now going towards email notification for them as well, for family members as well.
There are so many.
So, yes. So I just have to say that organizational leadership, the organization culture is huge. And in this pandemic, you cannot have a dysfunctional leadership team. You just cannot. Lives depend on it. And so I am grateful, and I can share that the team that I've worked with has been really, really awesome. They have caught this from before, and just like this picture said, we've been running ever since. We've been running since January. We're just trying to keep ahead and try to forecast what's coming. What do we do next? What do we need to change? How do we keep our patients safe? How do we keep our staff safe? How do we keep the community safe? It's really, really essential. It's really, really essential to have that leadership team. And so if you think in your own organization, Melanie or Carla, Sienna, if you think in the organization that you work with, do you feel comfortable with the team that's leading you through this pandemic? Because this is not only about what we're doing in the hospital, but what are we doing in our own practice? Dr. Love, how is Judson doing from a leadership perspective, guiding you through this change? this great change is huge.
I think Melanie had a great question last week, and it was in terms of unions. What do you do when uh, the union members are saying you can't force us to wear masks at
Mhm.
work? Yeah, yeah.
That's a tough one. I know I worked with this. The hospital that I work with now does not have a union. Um, and this is a tough one. I don't know if I have the answer to it in terms of the unions. I do know that the union does have a lot of leverage, and they try to negotiate with the organization. And it's really about, we have to look at what laws govern us. That's where we would start. Why can't you do this? And at least from a hospital setting, we have a risk. We have an obligation to do no harm. And we know
Right.
from a hospital setting that we must wear masks. Even before this pandemic, if you came in and you're septic, your body, you're really toxic, you have this huge infection that's just taking over your body. We are going in your room and we have a gown on, we have a mask on. So
Mhm.
we are used to that from a healthcare perspective. So I don't see us getting much pushback with that. Um, but what I've seen though is that we have had to, because of shortages, have had to lax some of those requirements because we don't have the amount of masks that we needed to do our jobs. And so we've had to make some adjustments there. But to say you cannot wear mask is not acceptable. As a matter of fact, I saw an email that came out from our organization leadership that says, I know the government says we can wear a cloth mask. And I will tell you that if you are working within our facility, that is not acceptable. You are allowed to wear it in the community, but once you report to work, that is not our standard.
Okay.
Mhm.
And that was a leadership
Mm.
immediate communication as to where do you wear a bandana, where do you wear a certain mask.
Mhm.
We have to follow the protocols in place. And I think healthcare, we understand that a lot more than maybe a manufacturing company or other companies. We're used to washing our hands all the time. And so that is something that we do all the time. So I don't think it's as challenging for us. But I could see where it is for other companies.
Lillian has a question too. She says, if the states whom are reopening right now cause a resurgence and overwhelms the hospital system again, would source contact tracing have to intensify to meet the demand? She said she was wondering how the SCT process will be implemented and if it will have built-in privacy protections, especially amidst the pandemic.
Yeah. Um, Contact tracing is challenging, and I know what I can talk from what we have done. There's a law that tells us we have to give each of our patients some information to say if you're positive, you will need to you're responsible to notify the people that you have come in contact with. And so we're giving them, we've been able to leverage technology. So if the patient is positive for the COVID virus, we give them a specific information within their discharge package, and it tells them to list all the people that they've come in contact with, and that they have to notify those to assist us with contact tracing.
Okay. So,
By also reporting to the Department of Health would help us with that as well.
okay.
Right. My understanding at our work is that if somebody tests positive for COVID,
Mhm.
then the health department gets involved, and it's not so much management or those people alerting others, but it's the health department that's doing that interaction with other people that might have been exposed.
Yeah, it's a combined effort. It's a combined effort because the health department don't know, they're not with you all the time, so we have to send that report to them. But then we're also asking you to help us part of that process as well. And at least in the
Right.
state of Pennsylvania, I could tell you in the state of Pennsylvania, which is the facility that I'm working with, I had to read that law thoroughly. We had to put that part information within our electronic system so that it goes out with the discharge instruction to the patient and what they need to do. to assist with notifying people that they've been in contact with. So it's a combined effort.
Right.
Yeah.
Right.
Nardalyn, how does the hospital determine which surgeries are critical and which can officially be delayed because of COVID-19? What's the criteria? What were the parameters?
Yeah, the surgery team knows that there's certain category that we assign when they schedule a case. We call it case, which is a surgery. They can determine if it's elective, and they would have to, if it's an elective surgery, you could filter that. So, okay, these are all the elective surgeries that we have.
Okay.
Then you're reaching out. If there's certain patient with certain diagnosis, they can look at that. So they can pull certain information from the electronic system and assess those patients. Like some of them is going to be clear cut that, yeah, this one, is a gallstone, or if it's chemo, if this patient is on chemotherapy and it's something that they consider more cosmetic, they may want to wait for that one, versus if it's a life-saving procedure that they're planning to do, and what is the risk benefit to that. So the surgical team is engaged, and again, they're able to run reports and say, these are all the surgeries we had scheduled for the coming month, and we can quickly just look and see which ones we consider based on the diagnosis for the patient, based on their comorbidity, based on the type of surgery that it is, classified under that those are elective, and we can postpone those. And then if the family has questions about that, then they'll have more dialogue with the patient and or caregiver at that time.
Are there any legal ramifications or implications because of the surgeries that's been delayed?
Um, there could always be legal implication to that, but I think we're living in the pandemic, and we just have to explain. And I think as medical professionals, I give the surgeons real good credit. They explain to, this is what the surgery is for. This is what we're trying to do. If we can, delay it, it's a risk to you. It's a risk benefit to you as well. We don't want to have you in surgery and then you're compromised at that point, under anesthesia, and you're in the hospital, and then you get exposed. And so I think patients in general, I haven't heard of anybody that, patients that would want to sue, stuff like that. And then we try to give them, keep following up with the patient, or have the patient follow up with you, the surgical team, to determine when can we schedule that surgery again. And that's a great question, because now that we're supposedly on the other side, I say supposedly because we're seeing that fluctuation again is changing. They're starting to schedule surgery, and they're putting certain parameters in place, like you have to be tested you have to have a COVID test within 5 days of the surgery, and have the results. So they're putting those parameters in place as well, so they won't just have a patient just show up before they do that. Like I said, there's always legal, but I think the health benefit, and if the surgery is not, the surgical team is not going to put themselves at risk, their staff at risk, or you at risk, in order to perform a surgery if they think it can wait for another month or two and make that determination. And it's usually in concert with the patient. And if the patient had a concern, they would look at the risk benefit, and ultimately they will definitely make a decision. If the patient is insistent and they feel like they can do it, they will, but in most cases you're erring on the side of caution, because then it becomes a medical liability as well. If they perform a surgery and you have a negative outcome, and then here you go. So it's better to have a preventative action versus taking a surgery and having infection, post-infection in your hospital.
Okay. Sienna has a question. She says, from a leadership standpoint, at what point do you notify your team, your office, your corporation that someone on the team has been affected with private protections in mind?
Immediately. I could tell you that from my team, I know only because we're meeting constantly, we get real-time communication as to when things are happening. I know not every organization is able to do that, but I feel like the leaders that I'm working with right now is really on the money. They're really on their mark. They're really looking ahead, and they're communicating. I remember when we had in the hospital the first COVID patient, it was very generic notification that was sent to say, we saw our first COVID patient in this hospital today. We don't give any names. We don't give where they are. We don't know what the outcome is, and stuff like that. And then we had our first death as well. It was very generic from leadership. Unfortunately, we had our first death case from COVID-19, and just want to send support to our family, again, without disclosing any type of information or violation. Only really if you are involved with caring for that patient will you know who this person is, because we have the laws that govern privacy protection called HIPAA that we cannot break. We can talk in generalities, but we should not be given any information unless you were involved in the care for that patient and had the needs to know. And for anyone who thinks they want to snoop and find that information, we will find you, because we have a security team that is looking at that. As a matter of fact, if somebody's tested positive, one of the things that we looked at is if somebody goes in that chart, an extra alert, you don't know it, but an extra alert goes out to our information, our security officer, or you have to do what is called break the glass to be able to see that information. And so you have to put your username, your password, and why are you entering this chart.
Oh,
And that gives
good.
extra VIP, we call it VIP flags, that is heavily guarded and tracked.
That's good.
Yes.
That's great information.
Mhm.
Additional questions? Oh, well, I have a question. I have a friend that is actually working at one of, I think it's Northwest Community, and she's had patients to come in that were on suicide watch because of COVID-19. And so my question to you is that, is there an uptick of mental health cases because of this pandemic?
I don't have the data in front of me to say that or not, only because we have certain hospitals within our system that sees a lot of psych patients, and so I don't know the number to that question if it's not, only because in nature we have a psych facility within our platform that we have that usually sees psychiatric patients, so with suicide ideation and stuff like that. I would have to reach out to them to see if we're seeing more of that related to COVID, or is just the nature of the business that the numbers are still just about the same. So for that, I'm not sure. But I know proactively they're providing services to the community, to the staff, just, if they want to just debrief with a professional, services, just because with what they've seen, some nurses, I mean, if you're dealing with death all the time, I mean, before it used to be one or two cases, and now you're inundated with just more death around you, and you have done your best and your patients are still dying. As a nurse, that's just hard to see, and it does take a toll. I don't care what anybody says, it does take a toll on you mentally. And so having the services available for staff proactively is really helpful. So to answer your question, I'm not sure because I don't have that data.
Okay. Well, she was personally impacted because she lost her son-in-law who was in med school to COVID-19, but at the time the state had not declared any deaths. And so when she drove down there, she and her husband drove down there, she was exposed, and her
Yeah.
husband was exposed as well. The kids were exposed. So they were at the hospital at one point, and then they were home. But the CDC was all over it. He went from a private room to they relocated him to the hospital ring cardiac care unit, and that's where other patients were at the time. And there were 7 of them, 5 of them died, and then he was number 6, but the CDC at that time still would not declare that it was COVID-19. He was 30 years old and had no pre-existing conditions. But so her life was turned upside down. It absolutely was. And then the body was on ice at the hospital because there were no protocols. What do you do when one dies of COVID-19? And so all of those things were happening, and it really, it was so traumatic for the whole family. Yeah, things have changed. They have changed. And so if someone dies in a family now, you may not be able to see them. Just everything changed.
That's the hardest part for healthcare now, which is why keeping that communication going, I know we've done a lot of Zoom meeting. We have different iPads that we've given to patients if they're able to utilize that. Um, and now we talked about just sending emails to say, can you let my family know what's going on? Putting that in that communication tool to nursing that's coming, because it's really hard. And I like what at least the state of New York is doing, which is right next door to us, so we kind of follow them as well, is that they are making those psychiatric services available. And I know some insurance companies, they're waiving those costs, the co-pays and stuff like that, so
Okay.
that the family can call and get help. If it's a medical professional, they're getting that service, at no cost is what I'm told. And so those services are now online. And so you could call and have this dialogue with somebody and at least see their demeanor, see their, body language. At least you can get that eyes on them
Good.
and just have that general communication. So these services are coming online as well to help family. It's just a tough situation. We're learning every day. We don't have it perfect yet. I don't know if we'll ever have it perfect, but it's a constant state of change and things that we don't know still, and we can only use the information that we have. So that's just a challenging situation all around.
Absolutely, because in that situation, they put a gag order on the family. They could not say that it was COVID-19 because it would impact. They both were medical students.
Mhm.
He also worked part-time with the police department, and so it would impact his life insurance policies, all of those things. I mean, so they were basically under threat not to say anything. So,
Yeah.
yeah, that
And
was
and
amazing.
that's a tough situation because um I don't know if there's a right or wrong to this, Dr. Love. Um,
It's new territory.
it's new.
I'm
It's
sure.
new,
Yep.
and you don't know how the lives impacted. As long as you're making this decision, always think, do the right thing. So as
Mhm.
long as the decision that they're making is doing the right thing, I will support it. But and not trying to hide. You know what I mean? Not trying
Yes.
to hide something from the public. As long as that's not the case, but always be upfront, and let people know what is going on. And I feel more comfortable in my world, even since January. I didn't really say much because I didn't know what was happening, but I was having all these meetings and I was like, something is happening that's not normal. Um, and I could see that,
Mhm.
but I couldn't say anything because I didn't have the full story to say. But as long as you're not trying to hide anything, I get bottled up when people try to hide things. Be upfront with your staff. Um, as honest as you can be without breaking any laws.
Mhm.
Um, and the more information people have, the better you are. They may be upset at the beginning, but I think ultimately they'll appreciate that information by you just being honest with what's going on.
Yes, absolutely. Absolutely. Are there additional questions for Nardalyn? Oh, they're all quiet, Nardalyn.
Hey, yeah, I have
I'm
a
just gonna hand.
question.
Oh,
I'm
there's
gonna end with this slide because
wait, before you do
yeah,
that,
this is. Oh, there's
Nardalyn, there's a
one. Okay,
question.
go ahead.
I was gonna say, do you have any information in terms of what other countries are doing in response to COVID? As far as like, are they opening up or still in isolation or stay at home? Do you have any insight to that?
I could share with you Jamaica because that's the next country that I have near and dear to me and what's going on there, only because of the mission that we have there and I still have family members there. I know last week for certain areas, they were in lockdown mode. And if they go to a community and find that anyone is infected, they are closing that community down for 14 days to try and contain the virus. So they're still trying to close down areas that are impacted by this virus. What they did before, they tried to notify the community to say, hey, there's a positive case or a couple positive cases in your area. And what would happen is that the people would leave. So what the
Hmm.
government is starting to do is that they don't tell them. They just lock them down. And
Oh.
so the surprise factor now to control it. So they've been doing that. So the lockdown is still happening. Um, it's more. I have to say it's more unified though. It's of course a smaller country. So let's be honest about that. It's a smaller country, but I feel like the government has really taken this in. He's using the military assistance. If a community is on the lockdown, if they need food assistance, whatever they need, they are having checkpoints, and so they're locking down. If there's any question, he's locking it down. And if there's any type of disrespect towards the government or what they're trying to do in terms of, just trying to prevent the community from getting infected, they will have a conversation with that person. And so they're locking down if they need to in the areas that are hot spots, and then they're opening when they can. So um, I think it's more um, structured a little bit. I was talking to Reverend Grant, um, both Reverend Grants in Canada
Mhm.
a couple of days ago about what Canada is doing. They remain in lockdown where necessary for essential services. They're getting paid, through their employer. Um, I think she said something up to 90% of her pay is covered so that they can stay at home. If you're able to go to work, then you'll get 100%. So they're enforcing those infrastructure, but they've remained locked down in certain areas based on her experience, um, and sharing that what they're doing. Again, another structured approach to opening the country or shutting it down. They're
90%.
still
My
climbing.
goodness.
So, well, the government offered 75%, and I think the employer added another amount to it. And she said, at least for her workplace,
Okay.
if you're able to 90%, but at least the government, you're guaranteed at least 75% of your pay, and that goes to your employer. It's not a direct hire or a direct pay or anything. She tells me it's to the employer that they're
Oh, I
keeping them
mhm.
employed
Yeah. It's
through that. So those are the two countries that I follow closely because I have closer connection with them, Canada and Jamaica, and they're doing a more structured approach in terms of not opening up too quickly and not afraid to shut it down. Um, she shared with me this that they had some protesters and they wanted work, and the government says, sure, if you could find a work, go and have it, because that's how we could address it. And of course, nobody's hiring, so they won't have any work. And I think that was the end of that conversation.
ah,
Um,
okay. That's a strategy.
that's a strategy. That's a
Yes,
strategy. I was
it
like,
is. Yes, it
you
is.
want to work? That's fine. If you could find somebody to hire you and go back to work, go ahead. I won't stop you. Um,
That's
so
definitely a
I
strategy.
just feel
it's
bad for
it's
the
a challenge.
people who have been stayed in place. I have a friend who is in Belgrade right now, and they actually have them on curfew. So I think they can
Mhm.
only go out like maybe 4 hours during the day, and they can't
Yeah.
go anywhere. They can't sit, anywhere, be in line anywhere, anything. And they're like having policed, all over the
Police
streets.
presence.
Yeah,
Yeah.
all over the
Hmm.
streets. And my friend's daughter, who's 22, was there studying. So she's stuck there. Her visa has expired. And she's, speaking of mental health, she hasn't had human contact in over a month. So right
Yeah.
now,
Wow.
it's just,
Wow.
her mental capacity has diminished because of it,
Yeah.
you know.
Has she been able to, use the other technologies that
She
is
has, but
available?
she was telling her mom, she's like, I haven't had a hug or a kiss or,
Mm,
or anything. And it's, for
hard.
her, she's already, she's had mental issues before with bipolar and things like that. So
Mm.
it's,
Yeah.
for her, it's very extreme.
Yeah.
That's
Yeah.
one of the things
Is
that
she in the countryside or in a more populated area?
I
Where's
believe
her
she's more in
location?
the populated area.
Populated areas.
Hmm.
Yeah. And that's the thing, for some countries, they are using their military services to enforce the laws. Um, that's yeah, that's tough
that's really tough.
situation, and what we can do to support them. Go
Yeah.
ahead. Go ahead, Dr. Love.
That even with Judson, when they made that determination that the students had to leave campus, but the international students are on campus, you still want to make sure that they have touch points and that they know that people care and that they're not totally in isolation, because you don't want to lose that community. You don't want to lose that community. And so we've been trying to reach out, but it's very difficult because the students are from another country. That is very difficult for them. And so we have to do things different. The paradigm has definitely shifted. In some areas, America at its best. I've seen continuity, I've seen it, and I celebrate it because of the fact that these are difficult times. But then on the other side of the spectrum is that you have people who, are concerned about feeding their kids and they need to work. And so now the weather's getting better, and so I'm not sure what will happen. Yeah, and
I am not
urban areas.
sure.
Yeah. So
and I'm very nervous. I'm going to be honest that I'm very nervous about where we are. And I've been listening to the leadership from my organization about what they're saying. But anything that we can do to support those that are isolated, I call it, we do drive-bys, we'll do a drive-by. Like my niece who's studying, she's an international student up in Oshkosh, Wisconsin. Now the entire campus is vacated and they've consolidated all the international students into one dorm.
Yes.
So that has taken a toll, can take a toll. Well, luckily she's a nursing student, well, qualified to be in the College of Nursing, so I could call her a nursing student now. I do a drive-by for her. We went up there, visited with her. We, because I know she works in this, the nursing home. We try to keep her a distance, but at least we're outside in open air and having that conversation away from her and just supporting her, making sure that she has, food. And the biggest thing was getting her a vehicle that she could, she was used to taking the bus and getting around there. And so now she had to take our Uber. She needed to get somewhere. So it's making sure now that she had a vehicle to be able to get around by herself, and having as much video conference with her, checking in with her, see how she's doing. But at least for her, she still is able to work because she's in an essential services as a CNA right now. And so she's getting out. But it's hard for international students being away from home.
Yes.
And not having the support. I'm going to tell the story and then I'm going to get back to you. I remember I traveled to Pennsylvania for work in the beginning of March, and I was watching the news and I was listening to everything, and I got nervous and I was like, I don't want to be stuck in Pennsylvania and can't get back home. I don't want to do that. And so I had that level of anxiety, and I immediately got on the phone with my boss and I says, I don't want to be here anymore. And I only just got there on Sunday and this was Monday, and I was like, I don't want to be here because the news was just changing so quickly.
Yes.
And I woke up on Tuesday morning and I took the first flight. I said, I'm not staying here. And he brought me a mask and says, that's where you have a good team. He stopped by, gave me a mask and says, travel safe. I'll see you online. And that was it. But I can just imagine being stuck somewhere, not having a family member there.
That's tough.
And that's something I didn't want to do. So I can just imagine other people that are in that situation.
Absolutely.
And so what we have to do, just encourage us, phone call, Zoom, WhatsApp for those people if you have an international connection. I'm just going to promote WhatsApp because it's great for video chats, for phone conversation. It's free for the person in that country, and here, as long as you have internet service, you can at least keep up with them and not having to pay an expensive phone bill for that connection. And so we can use that to support where we can.
Nardalyn, are your slides available to the students?
I can make it available. I'll have to make a couple edits, but I can make it available if you want that. Absolutely. I'm just going to close out with this slide. This is really emergency preparedness, leadership, critical. I heard you talk about toxic leadership. That is not helpful in this day and age. Not at all. It's a community, and we have to try and recover together. and we just have to manage through this. It's a dynamic, it's a paradigm shift, regardless of what organization you're working in. It is it affects you. It affects each of us. There's no right way to do something, but as long as you have positive intent behind it and communicate to your staff, communicate to your team, we just have to be strong for our community, and have our leaders be there for us and support us. But where you have a breakdown in that structure, that's where I become a little bit worried, because there's a lot to be learned yet, and they have to synthesize that information to help us as a community and as a country.
Very good. Questions? I have to call this team Team FNC, Friday Night Chats, FNC. So Nardalyn, I want to thank you. I want to thank you for your time, and I want to thank you for your expertise and knowledge. You just stop by and to share your knowledge with the students means the world to me, and as with them as well. I want to also just share with everybody about how Nardalyn she just cares for everybody. She absolutely cares for everybody. She has such a deep heart, and she is so knowledgeable of, well, everything, especially everything
that's
healthcare.
right.
She has expertise. Yes, she has expertise. That's very deep. That's very deep. But we're going to close out. I want to just share with you, next week we are going to have Antonio Shaw. He's from AbbVie Pharmaceuticals, and he's going to talk about the supply side pharmaceuticals from China and the impact that it has on us today. And so I'm excited about this information because it's all connected. We can talk about COVID-19 and from different aspects, right? It's from legal, it's from business, and from healthcare, and how it is impacted the infrastructure and the organizational culture. So I want to thank everyone for coming out and just being a part of this community. And Nardalyn, I say thank you, Miss Nardalyn. Your expertise and knowledge sharing was refreshing and informative. And Sienna says, so informative. Thank you. Thank
yes,
you.
I'm hoping that everybody learned something today. And if you have any more questions, I'll be happy to share. Again, this is my story, and everybody is going to have a story that's out there that could be more likely different from mine. But I have positive thoughts about us getting through this and working as a team to do it.
I believe we will. I believe we will. It's so funny because you hear language like, well, those that are at risk, maybe they should be at home or, shelter in place. And I'm thinking, that's not me. That's not me. Please don't say that. Don't put that restriction on me because of the fact that I turn into a different person.
To tell you the truth, we're all at risk.
We're all
I hate to tell you that we're all at risk.
Can I interject for just a second?
Yes.
Okay.
Sure.
I know, we are really short on time, but I just have to bring this up since you're bringing it up. In regards to people who are staying in home in place and the washing of hands, because there's so many these crazy YouTube videos and things like that are saying that people who are not subjecting themselves to germs, I think was it New York who was saying that people who are staying at homes are becoming sick right now. So is that a factor that you guys are concerned about? People who are staying in place are becoming infected because they're not exposed enough?
That is an interesting question.
No, that's I'm not sure. I would have to look at where they're getting that information from. You can't get home. You can't get sick by staying at home.
Well,
get sick with what? Like what type of sick though? Like mental health sick or virus sick or?
I mean, I don't know, but at the same time, I think about, as a kid, you're playing in dirt don't hurt, you know what I mean? But as you you grow, you build your immune system and things like that, you become immune to it. However, in this case, we're staying at home, our immune system is going down, and then we go out into the world and now we're exposed again.
I see what you're saying, because we, even in our homes, on our countertops, we're made up of germs. I hate to say that, it's all over the counter, the things, and yes, we all tell our kids when they're in kindergarten, yeah, they're developing their immune system. To say that blanketly right now, I think is a little premature, because this is a new situation that we haven't lived with before. And so we're learning about what that means for us. And so until we have the best way to protect us, um, I don't know if I totally agree with that. I understand what they're trying to do from the scientific perspective, to say, yeah, we're buildup of germs and we're not getting exposed to it. Um, I don't think I don't think we're ready for that discussion yet.
Hmm. Okay.
But I appreciate where they're coming from, because we need, we have good floras. We call them floras in the health system. We have good floras that helps to build our immune system, and when you get a cold, it help, our immune system kicks into place and it helps us fight that flu virus off. um but for this one, we're just living in a world where we just don't have enough information about this pandemic to make that, so we're trying to do our best to protect our parents or family. Eventually we'll start getting out again. Those germs will be there, but we'll know how to address it. So I
I,
don't know.
I was,
um
you just educated me on something, because I always thought that herd immunity pertained to like bacteria and regular germs. I didn't know that it actually contained to like viruses, because if my family member catches the flu, I catch the flu, but I can catch the flu again. I can catch a different strain. So
right.
there was never any immunity to the flu. I just had to get a vaccine or a shot to help me deal with it, to deal with the worst parts or the worst strains
Right.
of the flu virus. But I don't know.
And yeah, and if you think about it, think about this. I'm going to go back to the measles, because the measles is a disease that we've solved over time. We've known about it. Same thing, I'm going to go to HIV. HIV is something that when it came out, nobody knows anything about it, right? And everybody was so scared. And now we have learned more, and so we are less guarded. I would say, we kind of have more about how it's transmitted and all that stuff. Before we didn't, and so we protected ourselves, right, in general. Same thing for the measles. We now have a vaccine, and the vaccine helps us build our immunity to that. So if you're exposed to somebody, it builds the structure within your immune system to fight the body. Not going into all the technical things surrounding immunity, but the body helps to fight that off. So most people don't get that measles. We found out the other day that people that weren't getting that vaccine to help them suppress that vaccines were getting those outbreaks again for measles. And so once we learn about how to contain a particular virus or bacteria that helps our body fights it, then we can become less guarded. But until we know more about this, I'm okay sheltering in place if if you can do that. Versus saying, oh, we're not getting exposed and people are getting sick. I don't know what message you're trying to send here, but that's not a unifying message. In my mind, you're not doing a service to the community at this time. You don't have the data to make that determination. You're going from I don't know what. And I'll be curious about where they're getting that information from. And I kind of see what they're playing off, but I don't agree with it.
So some people equate the flu with the COVID-19 virus, but it's not.
It's different.
It's a different
It's
strand.
not. It is.
Yeah.
It is absolutely different. It has no. It is different. We don't have people in our hospital dying in such mass from flu
Right.
at all. We don't. And so to make that that's a false equivalence, in my opinion. To do that is irresponsible as well, because it's true. It's truly not.
Okay.
Over time, will we develop immunity to it? Yes, but we have to do it in a way that makes sense for your population, unless you're trying to get rid of your population faster. But let's get the facts and work together with what we know and change as we find out more.
Yes.
But thank you for sharing that. I believe I saw I saw that video talking about that as well, and I think I was a little disappointed with it.
Yeah.
Okay. Okay. Additional questions, comments? Ah. Nardalyn, thank you once again. You were fantastic, very informative. And listen, come and visit us again. You can be
Yes,
I
our
would
thank you
love
so much.
to.
yes, absolutely.
I
Thank you.
would love to.
And
Thank you all, and thank you all for joining. It was a real pleasure to be here, and I hope you learned something. And if I can share more, I would be happy to.
well,
All
as
right,
soon as
Thank
thank
you
you.
you.
edit the PowerPoint slides, let me know and I'll get them out to the students,
Okay,
to the
will
college.
do.
Okay. All right.
Yes,
Thanks,
thank
everybody.
you.
Have a great weekend and happy Mother's Day. Happy Women's Day. Okay.
Happy Mother's Day.
All
Yes.
right.
To you too.
Thank you.
Happy
Happy
Thank you.
Mother's
Happy Mother's Day.
Bye
All
bye.
right. Thank you. Bye.